Hello, Tim. Welcome to HTN Radio. I was hoping we could start with a quick introduction from you and a little more about what Signals is.
Absolutely, Martin. Thank you for having me. Big, long time reader and fan, so it's a true pleasure. Hi, everyone. My name is Tim Fitzpatrick. I'm founder and run Signals Group. Signals Group is a media and research platform entirely dedicated to kidney innovation and global kidney care. Very niche, so happy to be talking about all things kidney today. But really got our start a couple of years ago. I had been a founder. My last startup was a med device, improving the number of patients choosing home-based modalities in the kidney space. So think of it like a flight simulator for patients to go on complex medical treatments like home dialysis. So built that for about 8 years. And then 2 years ago, started Signals as a way to expand the conversations into the broader ecosystem. Kidney is, as we'll talk about today, pretty uniquely complex in a lot of ways in the way it gets paid for and administered. So now I get to do that full time and also doing a little bit of supporting companies through advisory who are thinking about all things commercialization, innovation, pre-commercial, pre-regulatory, all the way through public companies who are thinking about, hey, how do we position our stuff for this complex VBC market or what's coming next? So all things kidney all the time.
You said it was niche, and it's true. It's like a pretty niche end of the market, but it's not that niche when you think about how much the United States spends on kidney care. And I think that's one of the things that is interesting to both you and I. You used to work for DaVita, and think about the humble kidney. It's not something people think about a lot, but if you're interested in healthcare policy and financing, you really ought to be. You had a funny LinkedIn post about this the other day.
It is astonishing, right? So like many people perhaps listening, I too thought that, oh, kidneys, it's a kind of an overlooked afterthought of an organ or two. So many of my friends didn't know they had two kidneys. Just the baseline awareness is so low. But you're right. I mean, a quarter of Medicare spend is kidney between CKD and dialysis. One in three Americans at risk, one in seven have it today, and 90% are unaware. So it's this really interesting, sleeping, silent disease that is so closely linked with cardiometabolic health. That's why we're seeing all this push around CKM, for example, from the American Heart Association, from the National Kidney Foundation. The kidney's just getting blamed for all kinds of other diseases happening in the body. And it's, part of it is, oh, good, people are talking about kidneys, but also, all right, let's talk about how to fix that. Let's talk about how to bring cardiologists and primary care and endo into the equation. So it's kind of an exciting, long-awaited moment for kidney fans.
Well, it is Kidney Month, and I'm bringing you on to talk at this moment for a couple of reasons. One, you recently finished a three-part series on value-based care in the kidney space, which is very good, and I'll link to it in the show notes. And the second piece is Fresenius reported last week, DaVita reported the week before, and for 2025, the thing that was notable is that they had operating income for the first time in their value-based care businesses. And so before we get into some of how that works and what that looks like, can you help us set the table a little bit? It feels like there's been a lot of experimentation with value-based care arrangements and financing experiments in the kidney space. What are we talking about when we talk about value-based care when it comes to the kidney and kidney care?
Yeah, it's an important question to ask and to understand, especially in as you pointed out. I mean, CMMI has taken a number of swings at building innovative models that address this area of spend. This is not new, so people may have seen more specialty VBC lately, but this is already the second or third iteration in just the last 10 to 15 years. So the first focus, we talked earlier about how much spend is in kidney. A lot of that people typically think of dialysis. Yes, it is incredibly expensive. It is a disproportionate amount of spend for a relatively small population of patients. We're talking 5 to 600,000 patients in the US currently on dialysis. But that's over $50 billion a year in expense. So the first iterations of those models in the early days, the CEC model, were around hospitalizations and improving costs around that highest acuity kidney failure part of the spend equation. And then as models years went on, we saw the ESRD treatment choices model, ETC, that came out a little bit later, early 2020, 2021. And that was really focused on, again, kidney failure, but increasing home dialysis, increasing transplantation. That was sort of on the heels of the first Trump term's 2019 executive order on advancing American kidney health. So that also was a really big kind of, wow, look at, we're getting top level support on kidney things. And we're talking about these 80% goal, aspirational only, not a realistic goal, but a goal to have more and more patients dialyzing at home and getting a preemptive transplant. These are great things. And the model itself was mixed. It wasn't, it was sunset, so it was closed down last year. But then we had the new model already kind of getting started in KCC, which itself has had different iterations. And if you just have a picture in your mind, right? So we started with the furthest acuity, furthest down in kidney failure, and the models have increasingly moved towards earlier stage kidney disease. So from kidney failure up into stage 4 and 5 kidney disease, there are 5 stages. 4 and 5 are your advanced stages before your kidneys have failed and you need dialysis. That's where typically, hopefully, patients can start to see a nephrologist. It doesn't happen nearly enough. It's a separate issue. But these models are trying to find ways to make sure that transition, if it does happen, if and when it happens, from late stage advanced kidney disease into kidney failure is as smooth as possible. And so, to answer your question, the models themselves are figuring out what the right levers look like to enable that transition to be as seamless as possible, which typically means an optimal start. Maybe you've heard that. That means starting dialysis with a planned permanent access or getting a preemptive transplant. So AV fistula, AV graft instead of a catheter, right? Most patients who experience kidney failure are crashing into the emergency room, have no idea, often they have no idea they had kidney disease in the first place. So they end up in the ER, they're being told their kidneys have failed, and you need dialysis to survive, for life-sustaining treatment. So you're going to go to one of these 8,000 outpatient centers, and I know we'll get into that. But that's a really tough way to do it. It's not good for the patient. It's not good, from a cost perspective. It's pretty much however you look at it, it's not a great outcome. So what if we could manage those stage 4 and 5 patients, keep that total cost of care down, prevent that hospitalization, and have a start onto a dialysis prescription when the time is right. And so that's, again, the one theme I would point to is it seems like CMMI recognizes that the more we can do earlier on in the patient journey, which starts with identifying, detecting CKD as early as possible, and then treating those patients as early as possible, whether that's in primary care, cardiology, or in nephrology. That is what matters most. And so we've seen great outcomes in the latest model with KCC. I want to say 31% increase in optimal starts, 10% increase in home dialysis usage. There was 69% increase in preemptive transplantation. So these incredible clinical operational outcomes, but I think there's still some open questions on spend, right? Is this cost effective from the CMMI mandate perspective? I think that remains to be seen.
It's an interesting question. I think, sort of philosophically, when we talk about value-based care, we talk about quality and, are they getting the right care that they want, and cost. And these are often in tension. And so it's very hard to do both at the same time. It's amazing when it can happen. We'll talk a little bit more later on about the bundled payment system and how that has or hasn't really helped innovation in this space. But I think a useful next question for you would be, most people, when they think of kidney disease, they see either the DaVita or Fresenius logo in their head. They think of outpatient dialysis. There's actually a pretty robust landscape of companies who are operating in the space. It's not just DaVita and Fresenius. What does that landscape look like today? Who are the operators? What are they up to?
Yeah, so there are, as you said, quite a few. And what I've found probably most interesting about this space is that it is not maybe who you'd expect. So to your point, the two dominant dialysis providers in Fresenius and DaVita, they each have a value-based care arm, so to speak. So for DaVita, that's integrated kidney care, their IKC business, which we can talk to, have love to hear your thoughts, experiences there. And then Fresenius invested early in Interwell. They went through a three-way merger, just went through a recapitalization in the last 6 months. So they have Interwell. Beyond that, so that's two providers. There are probably another 6 to 8 that we track fairly closely, and then another 2 to 3 that exist, but there's just not that much out there to see how they operate and get any specifics on their model. But let's just call it 10 providers, geographically dispersed, all different sizes and again methodologies with how they operate, but the idea is the same, right? They contract with payers, often Medicare Advantage. Many of them do participate in the KCC model, and they are growing. They've started in nephrology. They partner with nephrologist practices. They've taken on more and more risk, which is a feature of the KCC model, to take up and downside risk. It's another separate set of learnings there for the last few years. But really, the interesting thing is now we're over 1.5 million managed lives, kidney lives, and close to about $40 billion in annual medical spend managed by these companies. So it's significant, and happy to talk about some of the overlap with ACOs, with cardiology VBC. I mean, these are oftentimes the same patients because, like we talked about with CKM. So it's as its own category class of company. Nephrology VBC is probably the most mature because it has had all of the efforts of CMMI over the last several years, and also the amount of capital, right? We're talking $2.5 billion north of that invested into just these types of specialty ACOs, essentially risk managers.
One of the interesting pieces that you put together for your three-part piece on value-based care is to talk about some of the levers that these companies have in pulling to help manage total cost of care, and be successful in those risk contracts. So could you talk through maybe what some of those approaches look like and what they're doing to actually, manage what is a lot of money in terms of care every year?
So one of the questions that we get often at Signals, right? So we not only do we spend a fair amount of time talking to these companies just to better understand how they see the kidney world, because they're not all the same, right? The entities, like I said, are structured a bit differently. They go about things differently. They have different ethos. If you look at how they're set up and what their care actual clinical model is and how they're designed, they can be a bit different. So one example to answer your question is they have increasingly started to manage other conditions. So in the last 12 months, we've noticed that the number of lives covered by these entities has skyrocketed, right? So just again, using public information, looking at how many lives that they've managed, we've almost doubled in the last 12 months that we've noticed. And oftentimes it's because they are managing cardiology in addition to some of these nephrology patients and more advanced CKD. So the way that they do that is it varies. So you often will see practice level supports. So coming in, it's likely similar. I can't speak to some of the other VBC folks you've had on before, but they have practice management. They'll have billing. They'll have some way to manage these contracts because there are so many contracts to manage and patients and attribution. All of those challenges are consistent from what I've seen and heard in our space. And so the real challenge that's unique to kidney, I think, is you do have dialysis. You do have higher levels of hospitalization and rehospitalization. you you have other ways to try to get ahead and predict when these patients need some sort of intervention from the set of care coordinators who are wrapped around them, who become incredibly important to keeping costs down because CKD is incredibly expensive. And I can't say that enough. Uh, Managing these patients' lives, their social needs, is so profoundly important and difficult to do at scale that it's astonishing to see how many lives are truly covered already by these groups. And I still think, and I ask this question pretty frequently, where are we in this evolution, in the maturity of these models? And most people would agree we're still really early, which is kind of telling. We've been at this, we've seen the federal models now for over a decade, and still they feel like they're just getting used to it, getting comfortable. The practices are now used to the people they're working with. The payers understand how to think about it and work on the shared savings side, and they have their own ways of working with these companies. But we're seeing fewer of the entities, let's call it 3 to 4 of them, managing 2/3 of the total lives we're talking about here. So there's a bit of a consolidation happening, and time will tell how that plays out in the next 12 months or so.
When you are looking at these contracts and you are managing, you're managing chronic kidney disease for this subset of patients, like what are the steps to success for this? Like what is you know, besides just like getting into a nephrology appointment and making sure that they have a relationship with a nephrologist, or like what are is it managing diet? Is it like, what does that look like?
Yeah. Yeah, I think it's a combination of things, which is the simple answer that hospitalizations is always going to be number one. I agree. And one very clear example of that, because I think it is, of the utmost importance. This week I was visiting a practice who had developed its own value-based care arm because it noticed that even the patients who had done all the right things according to VBC contracts and expectations, who had a planned access, so AV fistula graft, and were on home dialysis, they were finding that some of their patients were still going to the hospital if something felt off. And they were effectively fully managed, had access to all the members of the care team, were on medical nutrition therapy, like every possible benefit they could get access to, they had. So instead, what they ended up doing in this practice is building a 24-hour vascular center in-house where they could basically serve as an urgent care to help these patients keep the access. And if not keep the access, they at least had a way to give them the care that they needed and to avoid that level of hospitalization. Now, that one shows you just how much they have access to RPM, you name it, the things that are typically available in a value-based model. But the fact that a practice is willing to spend on its own to stand up a service line like that is really telling. And also that they would even try to go it alone, I think also speaks to this is not people like to talk about the inevitability of value-based care. And I agree that that is where things are headed. But how we get there and the role of partner entities and practices, I think that is still a difficult at times relationship where practices, they expect that if they're going to put all that extra work into making this relationship work and operating in this new paradigm, like they want to see something forward and understand what exactly they're getting. And that is also sort of an undercurrent that you hear about when you talk to nephrologists who are in larger practices who have worked with multiple value-based providers and maybe churned through. And that's not the kind of stuff that makes it to the news or that we read about, right? We see all the wins and the new partnerships, but it's not smooth sailing. It is hard. And even when you do all the right things and offer all the wraparound benefits for patients, the on the ground operations are just incredibly difficult. And the more time I spend just hearing stories, both from the patient or beneficiary side, in the physician side and practices, it's clear just how hard it is.
DaVita recently made an investment in a company called Elara Caring. They're in the home care space. You wrote a very good report on the rationale for the deal. I'm wondering if you can talk a little bit about the move generally, and then also, a thought that I had or something I learned when I worked at DaVita is the U.S. lags the rest of the world, especially Europe, in home care dialysis, and I'm kind of curious if you have a view on why that is. So a two-part question for you that are only somewhat related.
Yeah. I'll do the popular move and take the second one first. And I think it is an interesting thing to look at. The US does lag. I think some of those are US specific for good reason. So that's demographic population mix. That's the fact that we have 8,000 outpatient dialysis centers and we have this incredible infrastructure where people have the option to go dialyze in a center, and that's how our systems have been built. So it kind of cuts both ways. One, it's available, so people can go there. Two, most of the pathways, uh, entry on ramps to dialysis still favor the system we have. So that's partly answers that question. Um, the other thing is you'll notice within the US is massive. The US has all kinds of very, very different localized uh, models of care and things that bubble up in certain areas and don't in others. If you look at the rural areas of the states, they have higher levels of home dialysis because they don't have. It's much harder for them to get to a center for 12 hours a week. So 3 times a week, 3 to 4 hours a session. So those patients will often end up on home therapies. So that is the framing. There are more specific. Some states, some international states, countries have a PD first approach. There are things that make it easier to start at home that do not exist here. And again, we are our own worst enemy when it comes to how you finance something is how it operates. You can pretty much predict behavior in operations from the financial piece. So that again will always explain part of this equation. The thing about Elara that's interesting is this is not even close to DaVita's first attempt at home or interest in home or investment in home. So this has been around for quite a while. My last startup, we had done some work in this space with the LDOs around, again, helping patients understand home therapies, increase home adoption. This is in the wake of that executive order. So people were talking about it and everyone agreed this is the future. It's incredibly hard to uh, help anyone believe, one, become aware of home options. They're pretty complex. This is really one of the most complex medical procedures you can do, and you're being asked to do it on your own at home. There is no funded staff assist model, as much as we would love. Many people would love to see that model funded, and hopefully someday we will have that, even during the 90 to 120-day transition period, to have someone who's trained there to help you to make sure you're good to go. Not everyone is a candidate, so that's another challenge: is who are the right candidates, who makes the decision, what are the predictors, the number one predictors of success on home therapies. Well, turns out from the literature, it's patients' motivation, willingness. They can be taught. If someone wants to go home, you can. The right provider will help them get home. So it should be a relatively low bar, but it becomes quite difficult. Supplies, logistics, training, what to do, safety and troubleshooting, wraparound continuous support. It turns out that this is a tough thing to do. So that brings me to Elara, right? If you think about where DaVita sits, and not speaking for them, but just on the outside, thinking about they know how to offer these services. They've done it tens of thousands of times over in the patient's home. If they could find a partner who does high need specialty care for complex patients in the home, they've done that. That's all they do. They've staffed up a workforce that has trained professionals who know how to do exactly that. And now all of a sudden they have access to a new service line for a subset of their patients who certainly will need potentially dialysis at some point in their lives or at some point in their care, that's pretty attractive, right? So that is one way to do it. Another way that they did previously is co-invest in a joint venture device company. So Mozarc still exists. Medtronic, DaVita each contributed $200 million into that company to develop home-based dialysis technologies. Now that's still playing out, but that's just another way to kind of go at this, is to pair up a device manufacturer and a care delivery expert in this field and see where that lands. So the details, the devil's always the details, and I took a few uh, educated guesses in the table to see how they might think about the investment. I'm sure that what they're doing has some other benefit or cause or reason, like the justification and rationale for the investment, I'm sure will make more sense to us in a couple of years, or we'll never see anything more about it. Hopefully we learn a lot more about it and it works for those patients who need it. But it's an interesting model for sure.
One thing that I had never thought about until I started chatting with you about this stuff is, I had kind of always thought about a bundled rate as something that was part of a value-based care continuum. You put a bundled rate, and what that does is act as a forcing function to help constrain costs. And I think you have a kind of different view of the what the bundled payment system has done for dialysis, which has been in place for quite some time now. And so I'm curious to hear what role has that bundled payment played in the industry in your view?
Yeah. So the bundled payment's been around about 15 years, 14, 15 years. Uh, and essentially, like you said, it's setting a rate that gets paid to dialysis providers on a per treatment basis that allows them to, uh, it pro basically, they have to provide that dialysis service and anything else that is related to the dialysis service within that payment structure. So the unintended consequence of that, which at the time, dialysis costs were exploding. The United States realized they were spending a ton of money. And how can we do this? The logic is, makes sense. Let's do a bundled payment. Um, but the more things you add to that bundle, and the more you expect the dialysis providers to pay out of that bundle, a few things happen. I think the most important one is they become very good at uh, using their scale and their protocols. Again, two companies owning about 80% of all dialysis outpatient centers. Um, it's a scale game. So you become very good at making money quarter to quarter um, with a certain base rate that goes up around by about inflation on a yearly basis, sometimes less. So if that's eating at your margin, then you're not going to do a lot different, right? You're not going to be able to invest in research. You're not going to be able to invest in new drugs and all these companies, like my last company, who and others, so many others who want to invest, who want to be able to provide new services and products that improve the lives of people on dialysis and kidney patients in general, are incredibly limited. So it's a disincentive. And nowadays, a lot of us point to the bundle as an example of how policy and reimbursement can stifle innovation if it's done incorrectly. And that's a real challenge, right? Because if you're trying to build a new device out there, you're trying to create a new drug. Oral phosphate binders are a recent example where company created a drug, it was included in the bundle, company sued for putting it in the bundle because that was not the intention, and now they're doing right by patients and covering the costs for patients. But it's a real mess. And if you only have one of two acquirers, the whole founder's journey and capital allocation are almost cut off, right? And if you do that in a space where it's already $19 per person from a disease burden standpoint is invested in kidney research, so little NIH funding goes to kidney research, despite it being a massive amount of cost. That's a tough pill to swallow, no pun intended. So I spend a lot of time at Signals writing about that gap. We just don't have a great way to pay for innovation. The bundle has a lot to do with it. But the other side of that is we think upstream care, where VBC operates, where these ACOs in primary care operate, and whether they know it or not, they're treating kidney patients. So we want to solve for that. We want to find a way to make sure CKM is top of mind, that we can detect and diagnose it earlier so that we can slow by decades. If you get someone on the right diabetes drug, SGLT2s or GLP-1s, you can slow kidney disease progression by decades. So that's an incredible thing. All you have to do is take a blood test, take a urine test, confirm diagnosis, get them on the right treatments, and you're changing someone's life and you're reducing that cost of care. But the second you get down into the bundle, it becomes a tough conversation, with all kinds of implications for not only dialysis care, but access to transplantation, which is its own, should it be included in value-based care, pre and post, what happens for patients who are on dialysis and get a transplant? Should they still be included in value-based care models? They are technically an ESRD patient, right? But their treatment is a transplant. And chances are they may not, the rest of their lives, they'll be back on dialysis at some point. So there are a lot of unanswered questions and gaps in our current handling of dialysis and ESRD.
With this last question, I think I want to take a step back and get your view on where the industry is headed. When I listen to earnings calls, I hear about persisting elevated rates of mortality and mistreatment post-COVID. I also hear some optimism about tech and devices and pharma, and there's the outsized role that CMS plays in the business. So what should folks who are maybe new to the kidney universe be paying attention to this year?
Man, now is such a good time to be caring about kidneys. So first of all, if that's you and you're listening and you have not thought about kidneys at all before, welcome. It's lovely to have you. I would pay attention to a couple things. One, look at what CMS is doing. Look at what CMMI is doing. The new access model people are talking about, the new lead model. CKM is a pillar of those models. I mean, there's a good reason. There's a recognition, again, that it plays such an outsized role in your ability to deliver cardiology outcomes, to talk about and manage diabetes. Kidney matters. So there are a number, probably close to a dozen models currently or soon to be launched that involve the kidneys, from upstream CKM and early stage all the way to the IOTA model and transplantation. So if you care about policy, this is such a rich environment for you to get in and understand what's happening. Second, if you are interested in drug development, pharma, life sciences, that is also quickly becoming a really exciting, interesting space, especially with regard to kidney. So the number of rare kidney diseases with drug candidates in the pipeline or recently approved has taken off. There were no approved therapies for IgA nephropathy 4 or 5 years ago. Now there are 3, and there are 10 more in the pipeline. And FDA, CMS, regulators at large, patient advocacy groups are getting together, acknowledging that genetics play a role in a lot of kidney disease, finding ways to cover tests, to include them in guidelines, to get the voice of the patient more pronounced in decisions from regulatory bodies and how trials are designed and conducted, what endpoints look like, what a good endpoint looks like. And we're seeing more drugs come to market. So I know that those tend to be the 2 areas that at least my readership and people who care about kidneys pay attention. It's the life sciences, drug development, biotech, and then also the policy side. And so those are 2 very good reasons. There are plenty more from devices and diagnostics that I'm happy to talk about. But kidneys are a really rich environment. It is such a need. It's overlooked. We need all hands on deck. So if you care about healthcare, digital health, I promise there's an opportunity to to do something in the kidney space.
Tim, I was also hoping you could, as we wrap up this conversation, like I think your newsletter is great. And so,
Thank
what's
you.
the best way for people to subscribe, follow what you're doing, and keep in touch with what's going on in the Signals Group universe?
I appreciate it, Mark. Yes, Signals from Space or signalsfs.com is the main site for all things we do, media, advisory. Yeah, check it out. See, every week we write something new and interesting and try to do a fresh take on some very niche topic in the kidney space. So if you have any questions, I promise there's probably already been something written, hopefully something interesting, and we'd love to have you. So thank you.
Thanks so much for your time today, Tim. Really appreciate it.
Thanks for having me on.